Good day. As you know, I'm Dr. Rihanna van Zyl, and I'm the pediatrician working at the Center of Excellence at Pilanomi Hospital, where we manage children with complicated HIV disease. And today we're going to talk further on HIV and ART in children as we build on what we discussed in the third year. So if we have a short recap of what we did last year, we looked at the epidemiology, the pathogenesis, routes of infection, and specifically how that translates to the pediatric patients. We discussed the classification and staging, the clinical picture of the different opportunistic infections and the prophylaxis we use to prevent them, and then the diagnosis. How do we make it in children? Which tests to use and when? We spoke about the different types of ARV medication available and how to compile a regimen. And lastly, we did speak a little bit about the management and follow-up of these patients. So today we will be looking specifically at the new guidelines, the guidelines that were released last year, just to ensure that we are on the same page in regards to which tests we do when and what treatment do we start children on. We will have a look at the side effects of the ARVs that we commonly prescribe to children. I will say a short bit on iris. We will be looking at PNTCT in this lecture, and that is new information, as well as early infant diagnosis and treatment. In 2019, the National Department of Health released the ART clinical guidelines for the management of HIV in adults, pregnancy, adolescents, children, infants, and neonates. This is the most comprehensive consolidated guidelines that have been published. The previous set of guidelines were published in 2015, and there have been a number of changes since the release of the 2015 consolidated guidelines. For instance, in 2016, the Universal Test and Treat policy came into play, and there also have been a number of changes to the PNTCT guidelines. So please have a look at these guidelines. They are very easy to follow and quite self-explanatory. I will be using slides right from these guidelines throughout the lecture. Making the diagnosis is key when we think about managing HIV in any patient. In children, however, there are a few things we need to take into consideration. First of all, maternal antibodies transfer to the baby via the placenta when they are still in utero, and then via the breast milk. So if we do an antibody test on a very young child, then we cannot for certain say that he or she is actually infected. It merely indicates that there was exposure. So antibody tests make up the basics of testing in adults. Rapid testing is now standard of care, and it is an easy and effective point of care test where you can make the diagnosis and initiate the patient on treatment immediately. However, when we look at the antigen tests, where we look for specifically viral RNA in the blood, these tests at the moment are not available as point of care tests. So this means that making the diagnosis in children can be delayed, and therefore the new guidelines make specific recommendations in terms of timeframes for following up PCR results. So the big difference between antibody and antigen testing is the uses thereof in children. So antibody tests can be used for screening, but the diagnosis must be confirmed with an antigen test. And you will see why this distinguishing factor is important in the next slide. So once you know which test to use, obviously it's very important to know when to test. So for a number of years already, all HIV-exposed infants, irrespective of their risk, has to be tested at birth. And this PCR needs to be followed up within 3 to 5 days after birth to ensure that these very high-risk infants start on ARTs as soon as possible. The next PCR is only done at the 10-week immunization visit. Once again, all HIV-exposed infants, obviously who previously tested negative, will receive a 10-week PCR, irrespective whether they are formula or breastfed. Then, in the new guidelines, there is now an extra universal screening point at 6 months and a universal testing point at 18 months. And then lastly, if babies breastfeed for longer than 18 months, they need to get a 6 weeks PCR after full cessation of breastfeeding. The same applies if they stop breastfeeding before the 18 months. So whenever a baby stops breastfeeding 6 weeks after breastfeeding, they need a repeat PCR. But please remember that at any stage, if a child is symptomatic, test. This slide just shows you what the dried blood spot cards look like, and very importantly is how to correctly fill the circles. It's important that at least 3 circles are filled. They shouldn't only be drops. It doesn't help if you put 1 drop in each circle, and also the blood mustn't be flowing from one circle into another. 3 circles, or if you can complete all 5, that is wonderful, but at least 3 circles completely filled. As you can see, this slide was taken directly from the new guidelines, and as I explained to you, they now make very strict distinctions on when you can do an antibody test as screening, when it has to be confirmed by PCR, or when it is safe to do screening and confirmation with an antibody test. So first of all children less than 18 months old must receive a PCR as the screening test and the confirmatory test. It is allowable to do a viral load as your confirmatory test, as a positive viral load or any form of a detectable viral load will confirm infection. In the period between 18 months and 2 years, there might still be maternal antibodies circulating, especially if the baby is still being breastfed. And therefore, a rapid urine ELISA can be done as a screening test, but it has to be confirmed with a PCR. Once a child is older than 2 years, you can use a rapid for your screening as well as your confirmation. As I've mentioned, there is now a universal screening done at 6 months. All known HIV-exposed infants get their 6 months PCR, but infants who have not previously been known to be HIV exposed need to be screened for possible exposure. This measure was put into place as many babies were becoming infected via breastfeeding. So the mom tested negative during pregnancy but contracted HIV in the period while she was breastfeeding after birth. And this is an extremely high risk period for the infants to contract HIV. And therefore, you need to, at the 6 months well baby visit, check when last the mom's when last the mom was tested. If it has not been done within the previous 3 months and the mom is there with the child, you then have to do a rapid test on the mom to screen whether or not she's positive. If she then turns out to be newly diagnosed positive, you then need to go and do a PCR on the baby as screening as well as a PCR for confirmation. If, however, it's not the mom accompanying the baby to the visit, you can then do a screening test on the baby, and if that rapid test is positive, you need to then do a PCR. And then at 18 months, everybody gets universal testing. So this is for your HIV exposed infants as well as your HIV non-exposed or not known to be exposed infants. So at 18 months, all children must receive a rapid test as a screening, and if they then screen positive, they need to have a PCR as confirmatory test. And then lastly, just remember that other tests can be done at any time, except specifically your post-breastfeeding cessation PCR that has to be done 6 weeks after stopping breastfeeding. And with the new WHO feeding guidelines, HIV-infected mothers whose viral loads are fully suppressed are encouraged to breastfeed for at least up to 2 years. Therefore, a child can stop breastfeeding between 1 year of age up to the age of 2 or more. And therefore, an extra test can be done and should be done anywhere between your 18 months screening test. So if we're going into initiating ART in a little bit more detail, it's important for you to remember the viral replication cycle and the fact that we now have a drug to intercept at almost each point in the replication cycle. However, not all of these drugs are already in formulations that we can use for children. So we have the integrase strand transfer inhibitors, or the INSTIs, and the drug that we now have available is dolutegravir. Then we have the NRTIs, the NNRTIs, and the PIs, which are the older classes of drugs. However, there are a few new drugs available in each of these old drug classes. If we have a look at all the available ARTs for prescription, it looks like we have a lot to choose from. But as you already know, within the pediatric population, it is a whole different kettle of fish. As you can see, many of these drugs are not available in formulations that we can give to children. Or, for instance, due to tenafavir's potential side effects, it is not prescribed for children less than 12 or less than 35 kilograms. Once you've then chosen the correct test and confirmed the diagnosis, you need to move on to initiation of ART. And the new guidelines explains it very well. As you can see, the pediatric population is divided into 4 groups. First of all, your neonates or your infants that are diagnosed early with a birth PCR, and they are a category on their own and have their own initiation guidelines, and we will be discussing it a little bit later. The second group are your children more than 4 weeks of age and between the 3 and 20 kilograms. They are still initiated on first line that we discussed last year, which is 3TC, abacavir, and lopinavir/ritonavir. What is new is that the Kaletra syrup, which we know is extremely poorly tolerated due to the bitterness, there has now been a pellet formulation released, and it should be available in the state sector very soon. So the pellets are actually in a capsule format that the mom opens the capsule and then sprinkles the pellets onto soft food, and this is said to be better tolerated. Once a child is more than 20 kilograms, we can change the lopinavir/ritonavir to dolutegravir. So dolutegravir, as you might remember, is an integrase inhibitor, and it is much better tolerated, has a much better side effect profile, and it is also going to replace efavirenz in the adult regimens. So the cutoff to change to dolutegravir is 20 kilograms. As soon as a teenager then reaches the age of 10 and weighs more than 35 kilograms, they can be transitioned to the fixed dose combination containing tenofovir, 3TC, and dolutegravir, or we refer to it as TLD. This is just to show you the new pediatric dosing chart that was released with the new guidelines, and this simplifies everything. You just need the weight of your child and know what regimen, and then you can just read it off the chart. So if we now look at new information that we need to cover today, we are going to discuss the side effects of ARVs. And an easy way to look at it is to first look at your class-specific side effects and then look at some of the drugs who have very specific side effects that are special to them. So we'll start with the NRTIs, and the NRTIs is the oldest group of ARVs. And as they started developing ARVs way back in the 1980s, these drugs were extremely toxic, and patients often passed away secondary to these side effects and not from HIV-related complications. Luckily, with all the research that's being done, these drugs have really been refined over the years, and the new drugs that are, for instance, 3TC and abacavir, are actually very, very safe drugs, well tolerated, with an excellent profile when it comes to suppressing the virus. So the NRTIs, first of all, can cause mitochondrial toxicity. So if you think back on what the mitochondria do in the cells, you can realize that if you kill the mitochondria, you are going to run into trouble. So in adults, lactic acidosis was a huge problem, and patients often, like I said, died secondary to the lactic acidosis, and for that reason, stavudine has been removed completely from the formulary. In children, we are not especially sure why, but they didn't suffer from this lactic acidosis nearly as often or in such a severe state as the adults. However, they did develop lipoatrophy, and once again, stavudine was the main culprit, and for many years, it was one of the first-line drugs. What is important to realize is that the lipoatrophy is reversible if picked up early, but if a patient is left on a drug for a prolonged period of time, the physical changes are not reversible anymore. So these pictures just shows you clinically what lipoatrophy or the lipodystrophy syndrome looks like. They have loss of the fat tissue in the faces and in the extremities, and then redistribution of the fat in the central areas. So lipoatrophy in the extremities and lipohypertrophy in the central parts of the body. So you can see that the faces become thin with these sharp, thin chins, and they have temporal wasting. And then, unfortunately, the little girl in the bottom is well suppressed virologically with a good CD4 count. But due to being on a D4T or stavudine-based regimen for many years, she now has this permanent look on her face as if she is deathly ill. So apart from the lactic acidosis and lipoatrophy secondary to the mitochondrial toxicity, the NRTIs can also cause myopathies, neuropathies, pancreatitis, hepatic steatosis. But like I've mentioned, the newer NRTIs have a much more positive or a preferable side effect profile. If we then move on to drug-specific side effects, the first one that we need to highlight is abacavir. So we use abacavir in our first-line regimen for children, and it generally is very well tolerated. We have it available in multiple different formulations, and they are well tolerated. Also, it is a drug that can be given once a day, which obviously helps with adherence. But there is abacavir hypersensitivity that one just needs to be aware of. So hypersensitivity is linked to a specific HLA typing, which in the African population is very, very rare. So the incidence is about 0.2%. And therefore, in a country where we have a lot of HIV positive patients and very limited resources, for a side effect that is so rare, it doesn't make sense to screen every patient before we initiate them. Other than in, for instance, the USA, where the incidence is much higher, they have very fewer patients that's positive, and they've got lots of resources. They screen all patients by doing an HLA typing prior to starting them on abacavir. So even though you will not see this very often, you still need to be aware of the potential, as if it's not recognized, it can be fatal. The important thing to remember is that this is a multi-system pathology. It's not just a skin rash. If the child is taking the abacavir twice daily, as they usually do when they are younger, you can almost say it's like having flu twice a day. Every time the mom gives the child the medication, they develop some symptoms. The symptoms subside until that evening he gets the drug again and once again experience some symptoms. And classically, it's progressive, so worse after each subsequent dose. So for instance, the child can have general body aches, in other words, malaise, they can have a temperature, they can have abdominal cramps, they could develop diarrhea, they can have a skin rash, but it's not just a skin rash. So, abacavir hypersensitivity is multi-system pathology, so you have to have at least 2 systems involved, and it's classically progressive and linked to each dose of the abacavir. If you are challenged with a patient with possible abacavir hypersensitivity, you can request an HLA typing to be 100% sure. However, if it is a life-threatening situation, you can then stop the abacavir and switch. But please remember, once you've diagnosed abacavir hypersensitivity, that patient may never ever be re-challenged because it can lead to fatal anaphylaxis. So therefore, this is not a diagnosis that should be made lightly, and I would rather suggest that you discuss it with an expert before you label the child abacavir hypersensitive. The next drug that we need to look at is AZT or zidovudine. AZT is used mostly in second-line regimens, but as you know, we use it in our infants as part of PNTCT, as well as the regimen for the really small babies. So AZT causes bone marrow suppression, but what is important is that it does not affect your platelets. So if a patient presents with a pancytopenia and they are on AZT, you need to investigate for another cause. And secondly, the anemia that develops is macrocytic in nature. So if you have a patient that you've switched to second line and you do a full blood count on them after they've been on the treatment for, say, 3 months, there should be a macrocytosis. The anemia is rarely symptomatic and we don't often need to change the AZT. But you can imagine that in really small infants, specifically your premature babies, where they already have a problem with anemia and the immune systems are very immature, AZT needs to be given very carefully. And then lastly, we need to look at tenofovir and specifically the TDF formulation. Hopefully from the adults, you know that tenofovir potentially can cause renal function impairment. And the incidence is higher the longer you've been on treatment. Luckily, most children, the kidneys are still working fine and they do not develop renal function impairment. But what tenofovir can cause is hyperphosphaturia. In other words, when it affects the tubules, the patient loses phosphate through the urine, and this then obviously has an effect on bone mineralization and can in the long run lead to impaired bone growth and stunting. And this is something that we do not want in our young HIV positive patients, as they often are already stunted. Therefore, tenofovir and specifically TDF is not advised to give to children less than 10 years of age and less than 35 kilograms. If we then move to the NNRTIs, we basically only use efavirenz and nevirapine. Efavirenz is going to soon be replaced completely by dolutegravir, but you might still have children who do not yet qualify to go on to dolutegravir due to severe malnutrition and who are on an efavirenz-based regimen. So you need to look out for central nervous system side effects. So in the adults, they usually complain of dizziness and nightmares or poor sleep. It can lead to hyperactivity in children and also to depression. You should also be aware that if you have a patient who has a known psychiatric history, specifically of psychotic disease, efavirenz is contraindicated. Then they can develop a skin rash, but it usually is much milder than skin rashes that you find with nevirapine. Nevirapine is an extremely toxic drug. It also needs to be taken twice daily, and if you initiate a patient on nevirapine, you need to have a lead-in period. However, we use nevirapine still in PMTCT as it is currently still the only drug that has been proven to decrease breast milk transmission. And then in the very small babies, we simply have no other option, and we have to include nevirapine in their regimen as well. So nevirapine can cause severe hepatotoxicity to the effect that you can have fulminant liver failure. But notably also, it can cause Stevens-Johnson syndrome. There are a number of drugs that HIV-positive children are exposed to that can cause adverse drug skin reactions. These include, like I've mentioned, abacavir and then nevirapine, but also Bactrim. And it might therefore sometimes not be difficult or easy to distinguish which of these drugs are the causative agent. What is important is, though, to realize early that there is now skin involvement and then to stop the offending drug. If you do not make the diagnosis early enough and it progresses to Stevens-Johnson syndrome or toxic epidermal necrolysis or TEN, these children suffer severe morbidity and often mortality secondary to skin infections. And then lastly, we just need to look at the side effects of the protease inhibitors. The two drugs that we use in the pediatric population is lopinavir and then atazanavir in the older children. And remember, they are always boosted with ritonavir. Lopinavir, which is the oldest PI, can cause raised cholesterol, triglyceride levels, as well as an increase in glucose. So that means that these kids are at a higher risk of developing metabolic syndrome and therefore cardiovascular disease and diabetes later on in life. It can cause cardiac rhythm abnormalities, but that is very, very rare. Atazanavir causes an isolated hyperbilirubinemia, and this is not associated with any change in liver functions. It can just be managed on a watch and wait basis, and if the patient is not particularly bothered by the fact that his sclera has become yellow or that he might have a yellow tinge to the skin, these patients can happily continue on the AZT. The benefit of AZT over lopinavir, atazanavir, is that it's a once daily dosing and it's a capsule that is smaller than the Illuvia tablets. So we usually change the adolescents from Illuvia to atazanavir with ritonavir to improve adherence. So when we move on to IRIS, it literally means what the acronym says: Immune Reconstitution Inflammatory Syndrome. So this means that as the patient starts taking the ARVs, the immune system, we can say, wakes up and suddenly now recognizes pathogens that previously colonized the body during the early stages of the HIV infection. And then the immune system starts attacking these organisms, which then leads to clinical disease. One of these that we often find is TB. And that's one of the reasons why we need to screen all patients for active TB prior to initiating ARTs. So the higher the viral load at initiation and the lower the CD4 count, meaning the severity of your immune suppression, the higher the risk for IRIS. So if you have a patient that presents late in the disease, you should be wary of the patient developing IRIS. So there are two patterns that have been recognized, and it's either paradoxical IRIS or unmasking IRIS. So paradoxical IRIS is when you do screen a patient prior to initiation and you diagnose him with active TB. You start the TB treatment and then wait with initiating the ART. And then once you initiate the ART, despite being on TB treatment, they still deteriorate. Unmasking IRIS is the other side of the coin. You screened the patient prior to initiation. You did not find any clues or any confirmation of TB disease, but once you start them on ART, they then develop florid TB. What is important is to remember that iris occurs within weeks to months after initiating treatment. So if you have a patient who's been on ARVs for 2 years and then presents with active TB, it is not iris. So a few of the other conditions that commonly present as iris would be BCG adenitis. You can have PJP, cryptococcal meningitis, even herpes zoster, because that is also reactivation, hepatitis B, and you could even have autoimmune diseases that previously could not manifest due to the severe immune suppression. As this is an immune-mediated condition, these patients need to get prednisone for 2 weeks, but more importantly is to treat the underlying condition. Make the diagnosis and give the correct treatment. And please do not stop the ARVs. Because once you stop the ARVs, the patient might clinically improve, but you will just have a new viral replication, a spike in your viral load, and leading to further deterioration. We now move on to the prevention of transmission of HIV from the mother to the child. And I have mentioned before that there were also new guidelines released last year. The PMTCT is a separate guideline, and what is important to note is that it not only includes HIV, but also other infections that can be transmitted from the mother to the child, including hepatitis, listeria, malaria, syphilis, and very importantly, TB. So if we look at the different routes of transmission, a child can either become infected via vertical transmission from the mom, and to prevent that, we've got the PMTCT program. But it's important to remember that children can also become horizontally transmitted. So even though we have very stringent blood product screening, there are still a few patients who did contract HIV via blood transfusions. Unfortunately, we realize that children become sexually active very, very young, and therefore education on sexual behavior is incredibly important. There could also be an adult who had been sexually assaulting a child, and sometimes this is difficult to get from the history. But the importance is that knowledge about how to prevent yourself against contracting HIV is very important. For the purpose of this lecture and for most of our pediatric infections, we are going to focus on PMTCT. So a very key concept is that undetectable equals untransmittable. And this has been proven in the partner study where they used discordant couples where the HIV positive partner had a virological suppression and the patients who were not infected did not use any prophylaxis, and there was no transmission from the HIV virologically suppressed partner to the HIV negative partner. So undetectable equals untransmittable is not to be used as a go-ahead or a green light to now have as many sexual partners as you like. It still only works if you have a relationship with only one partner and the patient who's HIV positive remains extremely well adherent. It does, however, hold some promise in terms of transmission from a mother to her child. We do not yet have confirmatory results or research published, but we can conclude to a certain extent that if a mum's viral load is undetectable, she will not transmit to her baby. And therefore, it is the most important part of prevention from mother to child transmission that the mother's viral load must be completely suppressed. And in this slide taken from the guidelines, I just want to show you that for them also, they highlight the fact that viral load suppression is critical for the health of the mother, her baby, future pregnancies, and her partner. So it is vital that all mothers get tested preferably prior to becoming pregnant, but if not, once they fall pregnant, and then continually during the pregnancy, so that if she contracts HIV while she's pregnant, we can pick it up early and treat her. So when it comes to the infant, risk stratification is done based on the mom's viral load. And a baby is either determined to be a low risk for transmission or a high risk for transmission. And it's easy to remember because if your mom's viral load is undetectable at the time of delivery, you are at low risk of contracting HIV and therefore require less invasive prophylaxis. If your mother's viral load is more than 1,000, therefore undetectable, at the time of delivery, you are at high risk and you require dual therapy for prophylaxis. So, if we then look at the summary, you can either be low risk, and here it doesn't matter if you're going to be breastfed or formula fed, or you will be high risk, and here we need to make a distinction between the breastfed infant and the exclusively formula fed infant. So for the low-risk infants, it's easy. They get nevirapine for 6 weeks. They stop. Obviously, they receive their birth PCR, which was probably negative, and then they receive their next PCR at 10 weeks. The mom can continue to breastfeed without extra prophylaxis for the baby, provided that her viral load is fully suppressed. And the guidelines make provision for 3 monthly viral loads on a breastfeeding mother to ensure that there's no increased risk of transmission to the baby. High-risk infants who are being breastfed get nevirapine for a minimum of 12 weeks. And they get AZT for 6 weeks. And remember, AZT is a twice daily dosing. So it is a more complex regimen for these mothers, and it needs to be explained to them very well. So we say that they need to get nevirapine for a minimum of 12 weeks because we don't stop the nevirapine unless we know the mom's viral load is fully suppressed. So you start the baby on nevirapine after birth. 3 months down the line, you need to test the mom's viral load and ensure that it is fully suppressed. If not, the baby continues with nevirapine, the mom continues breastfeeding, but we then need to intervene to decide whether or not she needs to switch to second line or whatever other interventions are necessary. If you are high risk but exclusively formula fed, both the nevirapine and the AZT are only given for 6 weeks. Still nevirapine once a day and AZT twice daily. And this is just a reminder of when the HIV-exposed infants need to be tested. They get their birth PCR and they are followed up for these results between 3 and 6 days after birth. At the 6 weeks immunization visit, there are no tests done, but you need to ensure that if the birth PCR was positive, that it had actually been followed up and the child had been initiated, and also you need to check the mother's viral load results. If ever a baby has a positive PCR, you initiate him on the day you get the results, but you still do a confirmatory test. You don't wait for the confirmatory test to come back. You start immediately on the day you receive the results. If a baby remains or the birth PCR was negative, they then get their repeat PCR at 10 weeks. Also very important to note is that at the 6 weeks visit, you need to start them on their cotrimoxazole prophylaxis. Low-risk infants, you stop the nevirapine at 6 weeks if the mom's viral load at delivery was less than 1,000. For the high-risk infants, at 6 weeks, you stop the AZT, but you continue with the nevirapine for a minimum of 12 weeks, or for 1 week after all breastfeeding has stopped. So this would be in cases where a mom is failing on second or third line and she's prohibited from breastfeeding. You still need to cover the baby with nevirapine for a week after she had stopped breastfeeding. So just to recap again, when a baby is born, there's risk stratified into low risk or high risk, depending on the mom's viral load. If the mom's viral load is undetectable, irrespective if it was because she was on lifelong ART or she was diagnosed during the pregnancy but had started ARTs more than 12 weeks prior to the delivery, the baby is determined to be a low risk for transmission. If the mom's viral load is more than 1,000, it could be because she was newly diagnosed during the pregnancy and had not started ARTs before or during delivery. So these would be the moms that had tested negative all through the pregnancy, and then when they come in to deliver the baby, they need to have a rapid test done again, and they are then tested positive. So they had received no ART, and we cannot expect the viral load to be suppressed. Also, mothers who started ART less than 12 weeks before delivery. So this would be the mom who booked late and then had a premature delivery. If your mom was breastfeeding and she was later diagnosed to be positive, for instance, at one of the 3 monthly visits where the moms get screened, then you are also at high risk. And then lastly, all mothers who are failing on regimens who have a viral load more than 1,000. The babies are at particularly high risk. So low risk infants, easy, you get nevirapine once daily for 6 weeks. If you were high risk, you get nevirapine daily for at least 12 weeks and AZT twice daily for 6 weeks. If you are exclusively formula fed, the nevirapine is also only for 6 weeks. When it comes to the feeding options for a baby, they can either be breastfed or they can receive formula feeding. But you have to balance the risk of HIV transmission and the risk of increased mortality and morbidity related to formula feeding. For instance, babies dying due to pneumonia as they had no passive immunity from the mom that they should have gotten, or babies dying from diarrhea because the formula was not mixed using clean water, or even dying of malnutrition because formula is so expensive and then the mothers mix it incorrectly. So now that we know that undetectable is untransmittable, the risk of HIV transmission is far outweighed by all the benefits of breastfeeding. And for this reason, the WHO changed its guidelines on infant feeding and now recommend that all HIV-infected mothers who have an undetectable viral load should breastfeed for up to 2 years so that their babies can benefit maximally from all the nutritional and immunological as well as emotional benefits of breastfeeding. However, one cannot exclude a mom or tell her that she's not allowed to formula feed. But we need to ensure that they are adequately counseled and make the decision before the baby is born. If we use the AFAS criteria, it needs to be acceptable to breastfeed. And here, disclosure from the mom to the family is very important, as we know that grandmothers might want to immediately put the baby on the breast as soon as it goes, wah. It has to be feasible to safely formula feed. You have to have a fuel source, electricity or paraffin to ensure that you have clean water and also to be able to sterilize the bottles. It has to be affordable, and for very, very few people who only receive a child support grant, it will be feasible. You have to be able to continue for more than the first 6 months, so it has to be sustainable and it has to be safe. In the developed world, where usually all the criteria are met, they prefer to have patients on formula feeding rather than breastfeeding to ensure that there's absolutely no risk of transmission. Lastly, we need to look at early infant diagnosis. So I've said it a number of times that a birth PCR is done on all HIV-exposed infants, irrespective of the risk. And the birth PCR can either be positive, negative, or indeterminate. So if it is positive, you immediately initiate the patient on ART, but you still need to do a confirmatory PCR. If the birth PCR is negative, it simply means that the baby did not contract HIV intrauterine. So they need to be put onto prophylaxis as post-exposure prophylaxis for what happened during delivery. And once again, if the mom's viral load is undetectable, nevirapine for 6 weeks. If it's more than 1,000, then you need to give AZT for 6 weeks and nevirapine for a minimum of 12 weeks. And then remember to repeat the PCRs as per the protocol. The last scenario is when you have an indeterminate PCR, meaning it's not positive, but it's also not negative. If the birth PCR is indeterminate, you do not initiate the patient on ART. You repeat the PCR and viral load, stick the barcode on a referral letter, and refer that patient for further investigation. So at the beginning, I mentioned that the infants are a unique group of patients, and there is a specific algorithm for the management of these babies. The main reason we have them in their own group is that lopinavir with ritonavir, specifically the Kaletra syrup and the way it's formulated, is contraindicated to be used in infants less than 2 weeks corrected age, so more than 42 weeks post-menstrual age. So any baby, even if they are born at full term, will not be more than 2 weeks corrected on day 3 or 5 of life. So they cannot be initiated on Kaletra, and we therefore substitute it with nevirapine, as we have a lot of safety and efficacy data, and we have been using nevirapine in babies for very long. So if you think about the standard first line, it's compiled of 3TC, abacavir, and Kaletra. So we've now substituted the Kaletra with nevirapine. We keep the 3TC, but abacavir has not been established to be safe for use in children less than 3 kilograms. And therefore, from a safety perspective, we have to substitute that to AZT. So babies more than 2.5 kilogram with a birth PCR that is positive. On the day you have the birth PCR results, you need to do your baseline assessments, and this will include your confirmatory HIV PCR, your CD4 count, the full blood count, and the ALT. The full blood count because we are going to start them on AZT, and the ALT because we're going to start them on nevirapine. Remember, once you switch the baby to Kaletra, you need to do the cholesterol and the triglycerides to determine what that baseline is. Then you review them at 1 week of treatment. You check the blood results, including your confirmatory PCR. If your confirmatory PCR comes back as indeterminate or even negative, you follow the same route. You repeat a PCR and a viral load, stick it onto a referral letter, and refer the patient. You then see them again at 2 weeks and then at 1 month on treatment. You review them and then you adjust the medication. If they are now more than 2 weeks corrected and more than 3 kilograms, you switch them back to 3TC, abacavir, and Kaletra, and review them every month until they have completed 6 months of treatment. You do the viral load, and then you can continue to follow them up as any other patient. If the patient still weighs less than 3 kilograms, and remember they were more than 2.5 at birth, you need to refer these children to a pediatrician. If your 6-month viral load comes back as undetectable, then you continue and you only do a viral load and a CD4 again at 1 year of age. If the viral load is detectable, you need to look at adherence, review them monthly, and then repeat the viral load after 3 months. If it is still detectable, then you need to discuss with an expert. There is also a specific dosing chart for these babies on early infant diagnosis and treatment, so you don't need to worry about this. You might now ask, what about premature infants and dosing for them? And as these babies will usually be cared for in a specialized unit, you do not need to be worried now about how to manage them. But there are guidelines and dosing for the very small infants. Obviously, they will remain on this regimen for a much longer period. And that brings us to the end. There are a number of handy websites and apps that you can use. If you want to access the guidelines from the internet, it is available on Blackboard, but I would recommend going to the SAHIV Clinician Society website, go under Guidelines and then National, and there you will find all the latest guidelines and updates. Thank you for your time and stay safe.